All right. So, Assalamu alaikum, everyone. So, my name is Adil. I am a fifth year medical student. So, today I will be giving you guys a session on the pathology portion of your renal block. I tried to cover a significant amount of the portion that you guys have. Renal pathology is way too vast, more than I realized when I signed up for it. So, yeah, but I tried to cover as much as I can, and most of the high yield stuff, or like I think all the high yield stuff should be covered in this presentation, so you can put your emphasis on it. But all right, so we can get started. All right, so the first question is this. It's pretty straightforward. It's direct. Anyone have any ideas? What explains the BUN creatine ratio of over 15 in post-renal azotemia? The answer is A, it's increased tubular pressure. So let's look into what exactly these azotemias are. So, all right. So there's three types. There's pre-renal azotemia, there's renal azotemia, and post-renal azotemia. The word azotemia pretty much means that there is increased BUN in the serum, pretty much. But how does that happen? It could be due to a cause before the renal, or before the kidneys, or after the kidneys, or in the kidneys. So what happens with pre-renal azotemia is usually what happens is that there is a volume depletion. It could be due to hypovolemia as a cause directly. It could be due to congestive heart failure, things like that, where there's less fluids going into the kidneys. So the cause is before the kidney itself, so pre-renal. So what happens in this is that because there is less blood flow, renal blood flow, this activates the renin-angiotensin system and the renin-angiotensin-aldosterone system, which causes increased water and sodium retention. And this in turn increases the urea retention. So the ratio between BUN and creatine increases. So the ratio, which is normally 15, becomes over 15. So there's increased reabsorption of urea. So there's there's azotemia happening. So pre-renal azotemia. So, but what happens with renal azotemia is that the kidneys themselves are screwed up. So there's the absorption of the glomerulus uh, is like there's something wrong with it. So that's what happens with intrinsic or renal azotemia. This could be due to ATN, acute tubular necrosis, acute interstitial nephritis, any causes. So the absorption itself is messed up. So what happens in this is that there is increased urea being excreted. So the ratio becomes less than 15. So the ratio between BUN and creatine becomes less than 15. So there is more BUN being lost, or sorry, blood urea nitrogen being lost through the filtrate. So, and then comes post-renal azotemia. Post-renal azotemia is because of an obstruction after the kidney. So post-renal, after the kidney, there is a physical obstruction most of the time. It could be benign prostatic hyperplasia, it could be renal stones, it could be neoplasm, like a prostate cancer, it could be something like that. So basically what the obstruction does is, like this question says, and the answer says, it increases the tubular pressure. And with the increased tubular pressure, what happens is that because of the pressure, there is more reabsorption happening of the urea because of the obstruction. But there is a catch to this. If the obstruction persists, what happens is that the tubules which are under more pressure right now, they can get damaged. And when they do get damaged, the BUN creatine ratio goes the other way around because of the damage to the tubules, there is less reabsorption and there is more loss. It becomes almost like renal azotemia. So over time, it could progress. So that's pretty much a very, very short overview on this concept. Are we clear on that? Do you have any questions? All right, dope. So yeah, this is another picture just to give you the etiology on what these azotemias could be caused by. So pre-renal, most of the time, this is what you see. It is because of decreased renal perfusion, Intrarenal is due to direct damage to the kidneys, which could be tubular, glomerular, vascular, interstitial, like glomerulonephritis, hemolytic uremic syndrome, anything that could damage the kidneys themselves. And postrenal is the smallest portion or the distribution among these, and it is obstruction to the urinary flow. It could be a stone, it could be a tumor, it could be something like that. Another question on this. So I'll read the question. So we have a 67-year-old man. He's brought to the ER because of worsening shortness of breath. The symptoms are more severe at night when he lies down. He has a long-standing history of congestive heart failure. He recently stopped taking his medications for heart failure because he cannot afford it anymore. So his physical examination shows bilateral closed crackles on inspiration, serum creatine ratio. Creatine concentration is 2.3 increased. So urinalysis shows no CAS. Which of the following lab findings is most likely in this patient? So do we have any answers for this one? The answer is B. So we have a patient who has congestive heart failure, which is, congestive heart failure. So for congestive heart failure, what type of azotemia do you experience? What happens? It's pre-renal. For congestive heart failure, there is fluid, like a hypovolemia. So with hypovolemia, you have pre-renal azotemia. So with these findings, what you can see is that there is, as I mentioned earlier, there is increased aldosterone release because of increased RAS system activation. So there's increased serum urea absorption. So you have the crazy high number, which is 85 in here because of the high absorption. And there's urine osmolality is also increased in this patient because because of the water retention, because of the reduced, so because of the kidney, because I'm yammering, because the kidneys sense less fluid in the body because of the less fluid being flowed. Ultimately, what the body does is that it tries to retain the volume. So when it retains the volume, the urine that comes out becomes more concentrated, and the osmolality of that urine will be very high, which is why it is 700 in here. So that is why the urine osmolality is 700, and the urine sodium is 10 at this point because there is increased sodium and water retention, and there is there is a reduced fraction of sorry, and there is decreased fraction of excreted sodium as well. Is it clear why B is the answer? All right. I feel like in my explanation, I lost track of myself for a second. So if you did not understand something, do just let me know. All right, moving on to the next question. All right, so would anyone like to read the question?
4-year-old man comes to the physician for a follow-up appointment. 3 weeks ago, he underwent emergency cardiac catheterization because of myocardial infarction. He was hospitalized longer than expected because of decreased kidney function. The patient stays as his symptoms improved greatly. He's now urinating significantly more than before the procedure. The serum creatinine concentration is 1.6, and his blood urine nitrogen concentration is 20. The patient's at risk of which of the following complications?
Okay, so from how the patient is being described here, what do you think is the answer? It is hypokalemia, and I can explain to you why it is. So what's happening in this patient is acute tubular necrosis. So let's go through the question. So 3 weeks ago, he underwent emergency cardiac cath because of an MI, and he had decreased kidney function. And because of the decreased kidney function, and this pretty much means that because of MI, there's hypovolemia, ATN, ischemic ATN. That's pretty much what it means. So because of that, the patient pretty much had acute tubular necrosis, and the clinical course of this condition can be divided into three parts. Exactly. This patient is in the recovery phase. And how do we know that he's in the recovery phase? Because he's improving pretty much. He's urinating significantly more. His creatine concentration is normalizing, and his blood BUN concentration is also getting closer to normal. So he is at risk for hypokalemia. So let's quickly go over what exactly the stages are. So the initiation phase is around the first 36 hours from the damage. There is a decrease in the urine output and increase in the BUN. Maintenance phase happens after this 38-hour period, and it is pretty much like the disease state of things. In this stage, there is more oliguria. There is far less. Yeah, there's far less. Urine being released from the body, less than 400 milliliters per day, actually, which is terrible. And the patient is also hyperkalemic because the aldosterone system isn't working as well as it should be. And there is increased BUN, increased metabolic acidosis, and there is uremic manifestations. The patient could have uremic manifestations. What could that include? Do you have any ideas? The patient could be like it could be psychological. It could be things like that. Patient with high urea. That's what it pretty much means. Not in the scope of this block, I guess, to a big extent. Anyway, so yes, so coming to this patient, we have this patient in the recovery phase, where, as they mentioned, the urine, he's peeing a lot more. So his urine volume is 3 liters per day. Things are getting better. And he is hypokalemic compared to maintenance phase because there is so much fluid being lost without much regulation going on. So because of this unregulated loss of fluids in urine, the ions are lost with it, including potassium. So hypokalemia. There's also increased risk for infection, and as we saw in this patient, his BUN and creatine ratio are starting to return to normal. All right, if we're clear. Let's go on to the next question. All right, I can quickly go over the question. So we have a 56-year-old man. He comes to the ER because of a 3-day history of severe epigastric pain that radiates to his back and is accompanied by nausea and vomiting. He has a history of alcohol use. His BP is hypotensive, like 90/60, and his pulse is 110. So he has abdominal tenderness and there's distension as well. So the lab studies from a recent office visit were in the normal limits. This patient's condition is most likely to affect which of the following structures? What do you think this is? What is happening with this patient? And what do you think is the answer for this? So the answer is B, actually. It's a common confusion. Like actually, this I got this question from UWorld. So and the most commonly answered question was E, although it is wrong. Yeah, the most people answered E, but B is the right answer, and this is what your lecture says as well. I think there's like mixed, like there's old data that says E is the right answer, but the new data says it's straight segment. It's actually ischemic. It's not toxic. So this patient actually has ischemic ATN because of hypovolemia. See how his blood pressure is very low? That just pretty much indicates abdominal distension, hypotension, and less blood volume. To explain it further, 1 second. Sorry about that. Anyways, yes, so this patient has ischemic ATN. And his blood pressure is the testimony for that. And there is no history of him taking something that could be toxic. If it is toxic, as you mentioned, the answer would be E. It would be proximal convoluted tubule, which is affected the most, or first. So to have a quick overview of this, ischemic ATN, the hypovolemia is the most common cause. Could also be caused by systemic conditions like malignant hypertension, microscopic polyangiitis, even microangiopathies, tiny damages to intrarenal vessels, even hemolytic uremic syndrome, TTP, DIC. These conditions could also lead to uh, ischemic ATN. What's characteristic in this is that there is skip areas. I don't know how they might ask for this in your exam, but it could be something they ask about. Skip area. As you can see, there's parts that are red, there's parts that are green or blue or whatever color this is in this image. That means there's areas that are not affected, there's areas that are affected. It's like tiny focal, yeah, it's focal epithelial necrosis in the straight portion of the proximal tubules. And remember this word, CAM horsefall protein. Like they could give you like a tiny MCQ and ask you, okay, ischemic ATN, which of the following would you see in this condition? CAM horsefall protein. You could also see hyaline cast and hyperchromatic nuclei because of pretty much the apoptosis happening because of ischemia in these renal cells. All right, we have another question here. We have a 67-year-old man who comes to the ER for evaluation of 2 episodes of red urine. He has no pain with urination. He reports lower back pain and fever. 6 months ago, he was diagnosed with osteoarthritis, and then he manages with 1 to 2 tablets of ibuprofen and NSAID per day. So he takes 1 to 2 tablets of NSAIDs per day. He also smokes. He does not drink alcohol. He smokes very regularly and daily for the past 45 years. He has a fever. He's 38 degrees, and his blood pressure is 130. Physical examination shows a faint, diffuse maculopapular rash, bilateral flank pain, and the remainder of the exam shows no abnormalities. Urinalysis shows numerous eosinophils. So, what is happening with this patient? What is the answer? That will be acute interstitial nephritis or tubular interstitial nephritis. So the key words in this is the NSAID use, the regular NSAID use, and eosinophilic cast. I know that in your lecture it says that I think either with ischemic or toxic ATM that there is also eosinophilic cast, but for board's perspective or like for easy memorization perspective, when you see eosinophilic cast and the history adds up with the presentation of like with use of NSAIDs or something like that, it is acute interstitial nephritis. So like these are keywords particular to these conditions. So what could cause it? It could be infections such as acute bacterial pyelonephritis, like pyelonephritis in general, toxins such as drugs, acute hypersensitivity interstitial nephritis, which is AIN is the general definition of it. There could the use of analgesics over time, heavy metals, lead, cadmium, even metabolic diseases such as urate nephropathy, nephrocalcinosis, hypokalemic nephropathy, oxalate nephropathy, vascular diseases. Like there's a million things that could go wrong, but most of the time when you get an exam question, it's going to be very self-explanatory. It's nephrophilic cast, NSAID use, fever, and so on. A fever indicating that it has progressed to pyelonephritis. Even neoplasms like multiple myeloma could cause it. Immunological reaction, there's a million reasons why this could happen. Okay, next question. Would anyone like to read this one? All right, so we have a 72-year-old man. We have a 72-year-old man with type 2 diabetes evaluated for 3 days after being hospitalized for abdominal pain in the left lower quadrant. He took contrast-enhanced CT of his abdomen soon after admission. And prior to admission, his only medication was metformin. His current medications are insulin. He's currently on bowel rest, and his current medications are insulin, ketoprofen, piperacillin, tazobactam antibiotics. He does not have a fever. It's only 37 degrees. He has mild guarding and tenderness in his left lower quadrant. There is no rebound or rigidity. And the labs show this. You don't really need to look at the labs to understand what exactly is happening here. The history kind of gives it away. with the contrast enhanced CT and the tenderness and the in the left lower quadrant and guarding and whatnot. So what do you think is the answer for this? The most important thing from the labs itself are, I guess, that the presence of casts now, few epithelial casts. Other than that, the creatine is also increased and the urea is also increased. So all this adds up to the cause being the contrast administration, and what we have is toxic ATN. So this happens due to direct injury to the tubules by drugs, contrast dyes, myoglobin, hemoglobin, radiation, things like that. For your exam, at least for your university exam, what they'll mostly ask you is something like contrast or something straightforward like that. But it could also happen due to conditions like rhabdomyolysis and things like that. Okay, someone has a question, but he presented to the hospital before the contrast. How is it the cause? All right. So from how I understand the question, like honestly, I put this question before, but he presented to the hospital because of acute, yeah, he presented to the hospital because of the diagnosis of acute uncomplicated diverticulitis. Like that was his original condition. But he took the CT for the examination of the diverticulitis, and that's how he got ATN. Like ATN wasn't, this guy is just very unfortunate, I guess. Like he was already suffering from diverticulitis and he took the CT for the contrast CT for the examining or the investigation of the diverticulitis, and he ended up having toxic ATN. No issue. It's always tiny things like that that catches you off, to be honest. Like, anyways, yes, as mentioned earlier, the proximal convoluted tubule is the most commonly affected part of the nephron in toxic ATN. And it can also be caused by mercury chloride, I think there's carbon tetrachloride. Yeah, carbon tetrachloride, ethylene glycol. Yeah, and it's pretty much this. If the question mentions some nasty stuff like that, you know where it is going. Histologically, you can see necrosis, fatty changes, ballooning, and it's not very specific. The diagnosis you can make from it is from the history itself. Like this patient is very clear is that there was nothing wrong with him. I mean, there was something wrong with him, and then he took the contrast, and then things got worse. Like his kidney function got worse. He's retaining his serum urea. Urea has increased, creatine has increased, and he has CAS in his urine. Are things all good now? All clear? Dope. Amazing. Okay, so a few more pictures for, you know, association by memory. So the gross image could be something like this. Histologically, they could present like this. Not a huge fan of histology. All right, we're going to a different direction. All right, for this one, we have a 13-year-old boy. He was brought to the physician because of swelling around his eyes for the past 2 days. His mother also notices that his urine became gradually darker during this time. 3 weeks ago, he was treated treated for bacterial tonsillitis. He does not have a fever, 37 degrees, and his pulse is 79. BP is high, and he also shows periorbital swelling. Very, very, very straightforward vignette. The answer is yes, D. It's granular deposits of IgG, IgM, and C3. What do you think is the diagnosis? Yep, it's post-strep glomerulonephritis. Based on the history, the patient had a respiratory infection, bacterial tonsillitis, uh, most likely due to strep. And 3 weeks later, he suddenly has swelling around his eyes and dark urine. Very obvious, or let's say, what do you call it? Very straightforward vignette for post-strep glomerulonephritis. Actually, this image was not in the actual question on this, the one on the right side, but obviously this patient would, if they did an imaging and if they attached it, it would present the same way. He would have granular deposits of IgG, IgM, and C3 on immunofluorescence. All right. So to quickly go over them and go over what's happening with this kid. Post-strep or infectious glomerulonephritis, it's usually a little kid with a history of a respiratory infection. And the kidney stuff happens 3 weeks or by couple weeks time from the respiratory infection. That is important to remember. And the presentation is in a couple weeks. The patient will have hematuria mainly. You'll say cola-colored urine, very distinct for it. Azotemia, oliguria, less urine. And as mentioned earlier, he would have granular immune deposits. As you can see in the immunohistochemistry, it's granular. It's like it's powdery, I could say. Yeah, it looks powdery. And yeah, and the deposits are IgG, IgM, not IgA, and C3. So there would also be a deficiency of C3 in this patient because it gets deposited in the kidneys, as you can see here. Electron microscopy will have a starry sky appearance, as you can see here, or the immunohistochemistry. And one important thing they could ask you about in the exam is that what do you test for? What serum? Could you call it an antibody? I don't know. Either way, anti-streptolysin is tested for in these patients. So ASO titers are very sensitive for post-strep documenting. So to confirm the diagnosis, if the patient is positive for anti-streptolysin O, this just indicates that this patient did have a strep infection earlier, and what's happening here is because of that infection, and this is post-strep infectious glomerulonephritis. And this is the electron EM image, very zoomed in. You see a bit of humps. You see little humps in here. That's pretty much what characterizes this image. Right on. Anyways, so here we have a 22-year-old man who comes to the ER because of a 1-week history of dyspnea and hemoptysis. Dyspnea and hemoptysis. He has no sick contacts. There is no personal or family history of serious illness. His blood pressure is 152/90, and he has inspiratory crackles at both lung bases. He has no abnormalities. Hemoglobin is 14, which is it's pretty much normal, honestly. Yeah, it is normal. And his leukocytes count is 10,000, platelet count is 200,000, blah, blah, blah. Urinalysis shows proteinuria of 2 plus. And chest X-ray shows pulmonary infiltrates. Which of the following laboratory findings can you find in this patient? Yes, the answer is E. And can we have the diagnosis? Excellent. It is Goodpasture syndrome and IgG. So what if this patient did not have hemoptysis? What would you call this? Anti-GBM disease. Hemoptysis, Goodpasture. No hemoptysis, anti-GBM. That's really the difference. And in immunohistochemistry, you see very smooth, velvety, lights in here. It's prettier than the granular ones you see in post-strep. These linear lines are very characteristic for Goodpasture syndrome and anti-GBM. All right. Is everything clear so far? Great. Anyways, so next question. We have a 17-year-old boy who was brought to the physician because of a sore throat, non-productive cough, and bloody urine for 3 days. He has had over 2 similar episodes involving sore throat and bloody urine over the past year. His sister has SLE. He has a fever, 38 degrees. His his serum urea nitrogen concentration is 8 mg per deciliter. Creatine is 1.4. Urinalysis shows acantholysis and red blood cells. Renal ultrasound shows no abnormalities. A biopsy would show which of the following? It's IgA mesangial deposition. What we're dealing with here is IgA nephropathy, and that's is once again sore throat, respiratory infection. But in this case, he started having renal symptoms in 3 days rather than in 2 weeks. So this is what pretty much makes the difference between the two, between IgA nephropathy and post-strep. They both have near similar descriptions. The SLE mentioned here is a distractor. His sister has SLE. It doesn't mean that he would. What's important about this patient or this guy is the sore throat. And after 3 days, he started having 3 days. Yeah, the distractor distracted you. That happened. I mean, I guess they succeeded, whoever wrote the question. And also, I'll get to this later on again, but capillary wire looping is not specific for systemic lupus erythematosus, by the way. It pretty much means membranous nephropathy as well. So I'll get to that point. It's kind of like a teaser to later on, I guess. So to give an overview on IgA nephropathy, IgA deposits, self-explanatory. The patient has IgA deposits. In post-strep, he has IgG, C3, IgM, all that bullshit. And the clinical presentation can be similar to post-strep glomerulonephritis, hematuria, recent respiratory infection, but 3 days, 2 days, something like that, rather than weeks. The difference, yeah. And then it could be associated with celiac disease. It could be messenger proliferative, focal. It could form a crescent. What crescent formation means is that it's gone way too far. Like it's pretty bad. That's what the crescent formation means. Like at that point, things are dangerous. And one more thing is a Heenan-Schönlein purpura. It's pretty much IgA nephropathy with a tummy ache and skin rash. Like it's mentioned in completely different lectures for you guys, but they don't really know the source of why both of these happen. Both these conditions just happen, and it's hypothesized that the reason for both conditions are the exact same. The only difference is that Heenan-Schönlein purpura is IgA nephropathy with the stomachache and skin purpura or the petechiae that you've seen. I've not put emphasis on it, but I think you have the image. If you don't know what the skin purpura and Heenan-Schönlein purpura looks like, you should Google it, find out. It's very similar. It's very simple. It's just red marks, red little shapeless rashes on the legs or the stomach. And Heenan-Schönlein purpura, it's not necessarily a prior resp infection. It could be like a GI infection as well. That's one difference between them. But to keep things very, very simple, IgA nephropathy, Heenan-Schönlein purpura is pretty much IgA nephropathy with a tummy ache and skin purpura. All right, before we go further into it, I want to just review what the difference between nephrotic syndrome and nephritic syndrome is. All right, so nephrotic syndrome, the proteinuria is more. There is 3.5 grams per day. If the vignette says 4+4 proteins in urine, that means it's nephrotic syndrome. You lose albumin. There's hypoalbuminemia, so the patient could have edema. They could be fatty CAS or no CAS at all. Hypogammaglobulinemia, less immunoglobulins are lost and increases the risk for infection. Loss of antithrombin 3, which increases the risk for a hypercoagulable state. And the patient could also have hyperlipidemia. Like these are like lipid levels and coagulation condition or concomitant infection, things like that are something that they could bring in your question vignette, either in your uni exams or your board exams to divert your attention towards nephrotic syndrome. Nephritic syndrome, on the other hand, is that limited proteinuria, less than 3.5, hematuria. You can also see hematuria in nephrotic syndrome, but it's kind of late stage. And hypertension is actually is characteristic for nephritic syndrome, but in very late stage nephrotic syndrome, like the crescents are there, it's sclerosed, the kidneys are gone at that point, or I don't think it even needs to get to that point. If it's pretty late stage, you could also see hypertension in nephrotic syndrome. Oliguria is seen in nephritic syndrome, reduced urination, and there's glomerular infection. Like, the itis. So there's an itis happening here. There's an inflammation or inflammation happening here. Is the difference between nephrotic and nephritic syndrome clear? All right, great. So let's talk about a 36-year-old man. Actually, I'm tired. Does anyone else want to read?
A 36-year-old man comes to the physician with 4-week history of swollen legs. He has difficulty putting on socks because of swelling. 2 years ago, he had sleep apnea. He was diagnosed. Takes no meds. He came from Guatemala, and he's 171 centimeters, 115 weight. His BMI is overweight or obese. His pulse is 91, and blood pressure is 135/82. His periorbital and bilateral lower edema, and they show the renal biopsy and the uh, CBC, I think, or in the urine analysis. You're asking what specimen would we find?
All right. Thank you so much for reading. Anyways, so do we have a diagnosis here? Yes, it is E. But what do you think is the diagnosis here, and why D? Why E? Yeah, Guatemala is pretty good. Yeah, Guatemala also adds up, but it could. Another thing is the BMI itself. Obesity is a good cause for focal segmental glomerulosclerosis, which is characterized by segmental sclerosis of the glomeruli. And yeah, it's nephrotic syndrome. Protein is 4. It's honestly, it's the distinction between the two. It's not what really stumps you in most questions, nephrotic and nephritic. But yeah, it's segmental sclerosis of the glomeruli, and as you rightly mentioned, it is focal segmental, and because of the obesity is another cause for it. Yes. So what it pretty much means is that focal, only some glomeruli are affected. Segmental, only some parts of the glomeruli are affected, and it is still nephrotic syndrome and you're still losing protein a lot. Like most of these like a lot of like actually all of these conditions, it could be primary. All of them, like anything you have in these, they could all be primary, and it could also be secondary, and it could be secondary to HIV use, HIV, heroin use, sickle cell disease, obesity, and it could be part of other conditions like IgA nephropathy. Nephropathy could progress to focal segmental glomerulonecrosis, glomerulosclerosis. And in this, you can also see hypertension. And the issue with this condition is that they usually have a poor response to steroid therapy. And this kind of looks like wire looping too. All right. Next question. Can go ahead. We have a 6-year-old girl, increased swelling around her eyes for the past 3 days. By this point, you should be able to have the answer. But anyways, so 6-year-old girl with swelling around her eyes and periorbital edema, abdominal distension, shifting dullness, just more to the edema, and serum albumin is 2. Like by this point, you know that this is nephrotic syndrome, and serum cholesterol concentration 290, hyperlipidemia, nephrotic syndrome, proteinuria, fatty cast. Histological examination is most likely to show which of the following? It's a very classical nephrotic syndrome, 6-year-old girl with periorbital edema. Any answers? Yep, it is normal glomeruli on microscopic and on light microscopy. Minimal change disease. You're right. Option C says effacement of foot process of podocytes on light microscopy. This is like a tricky way to put options because you do see effacement of foot process of podocytes in minimal change disease, but not on light microscopy. In light microscopy, things look perfectly normal. But where you do see it is electron microscopy. So in light microscopy, you see normal glomeruli in minimal change disease. So this can be associated with respiratory infections, immunizations, atopic disorders, Hodgkin's lymphoma, and what you you only see it in electron microscopy. You see uniform and diffuse effacement of the foot process. And as seen in the question minute, the patient also has hyperlipidemia, and the proximal tubules could be lipid laden. They could have something called lipoid nephrosis, very characteristic for minimal change disease. And the immune staining, it is negative. It shows almost nothing. and there's massive proteinuria, but the renal functions are fine. And one good thing is that it has very, very good response to steroids. So after a steroid treatment, the patient is good to go. Next question. We have a 69-year-old white man who comes to the physician because of a 15-day history of fatigue and lower leg swelling. Over the past 8 months, he has a history of he had a 3.8 weight loss, 1 pack of cigarettes daily for 48 years. Vital signs are normal. He appears thin, 2+ pre-tibial edema bilaterally. His X-ray shows a right upper lobe density. And the labs show this. What do we have in the labs? Proteinuria, numerous fatty casts, pretty distinctive for nephrotic syndrome. And in the light microscopy, what you see is thickening of glomerular capillary loops and basal membrane. There's thickening of the capillary loops and basal membrane. Yes, the answer is D. It's membranous nephropathy. Let's talk a little bit more about it. Did I not add a slide for it? Okay. Oh, never mind. There's one more thing. Yeah. So let's say we have the same patient. There's a 24-hour collection of urine, showed proteinuria, and yeah, once again, it showed the examination of the kidney biopsy showed thickening of the basal membrane, but the electron microscopy showed dense subepithelial deposits, and further examination or further evaluation is most likely to show which of the following. It is once again D. It's D. It's antiphospholipase. Antiphospholipase A2 receptor antibodies is very, very characteristic for membranous nephropathy. So when you know membranous nephropathy, what's being described as membranous nephropathy, it is antiphospholipase A2 receptor antibodies. Where did we see B? Anti-C3 convertase. I honestly can't remember. I'm sorry. I don't think it's in membranous nephropathy. Or else it wouldn't be in the options. I got this question from Ambas. I didn't make this up, so I doubt that they will be wrong. But I honestly cannot remember where you see anti-C3 convertase, but it's not characteristic. Yeah, I've seen it too, but it's not striking in my mind. If I remember it over time, I'll bring it up. Anti-C3 convertase. Anyways. Yes, membranoproliferative glomerulonephritis type 2. That's where you say it. Right. Yes. Yeah, it's not something I included in the questions. But yes. Thank you, Sarah. All right. So let's discuss membranous nephropathy a little bit. All right. So membranous nephropathy is a common cause of nephrotic syndrome. Yeah, I don't think. Yeah, I don't think it was in the slides. The slides for membranoproliferative glomerulonephritis, they were weird for me to actually. I tried to understand it. I went through AMBOSS. AMBOSS has like a very, very good description on it, so I would recommend it. Your exams in a few days. Get the 5-day trial if you don't have it. Go through all of it. It really helps. It genuinely really helps if you want to recall everything. But at the same time, the issue is that what your lectures have, the information is like no comment. Anyways, so membranous nephropathy, back at it again. So it's a common cause of nephrotic syndrome. There's diffuse thickening of glomerular capillary wall, and there's IgG containing deposits along the subepithelial side of the basal membrane. This is the text you should be looking for if you're suspecting membranous nephropathy. In most cases, it is idiopathic, but it can be secondary to drugs, cancers, SLE, infections, and other autoimmune diagnoses. See that SLE pops up anywhere. And if you went through the lectures, I'm going to get to SLE, but it's just something that really annoys me. With SLE, it could be literally any of these. Like literally any of these, it could present the same as a different stage of SLE. And spike in dome appearance in the electron microscopy is very characteristic for it. And you can see wire looping, but this is also seen in lupus nephritis. Antiphospholipase A2 receptor antibodies is characteristic for membranous nephropathy. So is membranous nephropathy clear? All right, amazing. So yeah, you can also see that there is a progression in the thickening of the capillary walls. Like in the first image, you cannot really obviously say it unless you're a trained eye and you're looking for it. But in the second image, you can see that the lines, it's thicker. And this characteristic image of like, like strings like all clumped up together, that's pretty much what wire looping is. Okay, we have a 34-year-old woman this time. Comes to a physician because of 1 year history of episodic pain in both wrists and recurring rash. She reports chest pain on deep inhalation and fatigue that causes her to quit dancing classes. Her only medication is occasional ibuprofen for the wrist pain. She's sexually active with one male partner. They use condoms, and she does not smoke or drink. Her vitals are normal. Physical examination shows an erythematous rash on the extensive surface of the arms and the hands, over the cheeks, over the nasal bridge, spraying the nasolabial folds. She also has ulcers on the hard palate. You know what's going on at this point. You knew what was going on way before, I guess, because of the rashes and the sparing the nasolabial folds. Lupus. Yeah, this patient has lupus. Serum creatinine is not terrible, but that was at a visit 2 years ago. And if you did a renal biopsy, which of the following would you be seeing? Yes, that is a big ass bottle. But let's get back to the question. Yes, it is. It is glomerular immune complex deposition. This is the most simple or the most straightforward thing that happens with lupus. There is glomerular immune complex deposition. So if you see that as an option and a vignette for lupus, and here's how you distinct between the progression of the disease. The creatine concentration is still 1.4. It was 1.2 2 years ago, and it is still 1.4. It's not bad. It's not terrible. The patient isn't really going through it so far. So the creatine concentration is only 1.4. So she's in very early stages. So the most basic thing is all that you will see in the kidney biopsy, which is glomerular immune complex deposition. Let's go over lupus nephritis. Immune complex deposition of the glomeruli, peritubular capillaries, basement membrane, and larger blood vessels could be seen in lupus nephritis. Immune complex consists of, this is supposed to be of, DNA and anti-DNA antibodies. This could be an MCQ, very straightforward. You see a granular pattern in the immunohistochemistry, the powdery stuff. You see wire looping in class 4 and 5. And number 5 says membranous lupus nephritis. And your slides also say that there's a lot of overlap between stage 4, class 4 and class 5. So membranous nephropathy, lupus nephritis, diffuse proliferative lupus nephritis, all three of these have kind of similar presentations, and they all have wire looping. That's one way to remember it. If you see wire looping, it's either class 4 lupus nephritis or class 5 lupus nephritis, or it's just membranous nephropathy. And none of these patterns are specific for lupus. Is lupus clear for everyone? Great. All right. Simple question. 34-year-old male presents with bloody cough, hematuria, proteinuria, red cast cell. He's negative for anti-nuclear antibodies, but positive for C anti-neutrophilic cytoplasmic antibodies. Which of the following would you expect to see in the immunofluorescence staining in this patient? What do you think is the answer? Oops. Oh, well, spoilers, I guess. It is B. There is no deposit seen in C ANCA conditions. In these, I guess this one's, I honestly cannot remember the vasculitis, but yeah, this patient has a vasculitis, and he also has kidney involvement. He is C ANCA positive. And yeah, and you don't expect to see any deposits. Yes, yes, it's Wegener's. This is Wegener's. So with C ANCA positive, you don't expect to see deposits or any of these C ANCA, P ANCA, whatever it might be. Number 16, 17-year-old male presents with hematuria and end-stage renal disease. Has family history of ESRD. During the appointment, you notice that the patient or the boy is wearing a hearing aid. What is the etiology of the patient's presentation? Another very simple, straightforward question. Yep, it is Alport syndrome. And the answer is D, actually. Uh, it's not the thinning of glomerular membrane. It's the defective collagen type 4 is what's so characteristic about Alport syndrome. And yes, it is an issue with type 4 collagen, and the patient will have end-stage renal disease or renal failure with hearing loss, but he could also have lens dislocation. So pretty much it's a collagen issue. So wherever type 4 collagen has a strong function, like in the eyes or the ears, there could be an issue. It could be lens dislocation, and it could be hearing loss. Uh, in Alport syndrome, there is irregular thinning and thickening. Like some parts could be thinning, and some parts could be thickening in glomerular base membrane. Is that clear? Is that understood? Great. All right. So for the next patient, we have a 17-year-old woman who comes to the physician because of a 4-month history of because of a 4-month history of fatigue, worsening swelling of her ankles, and a 5 kg, 11-pound weight gain. Neurological examination shows diminished 2-point discrimination in her fingers. Lab exam shows hemoglobin HbA1c of 9.2, a creatine concentration of 1.3 mg, and urine dipstick shows heavy proteinuria. A biopsy specimen of the patient's kidney is likely to show which of the following? So let's look at the important stuff. She has swelling, she has weight gain, she has a diminished 2-point discrimination, she has 9.2 hemoglobin, and the answer is nodular glomerulosclerosis. This is all you need to see, like the HbA1c. This is diabetic nephropathy. So in diabetic nephropathy, there is underlying microangiopathy. There is diffuse thickening of the basement membrane of the capillaries. And this could be in the glomeruli, it could be in the medulla, it could be in the tubules, it could be in Bowman's capsule, it could be all over the place. And there's also renal vascular, like the vessels themselves, they could have arteriosclerosis. And what's characteristic about diabetic nephropathy and histopathologically is diffuse mesangial sclerosis. And the most important thing is what the question put up as an option, the nodular glomerulosclerosis. You see these tiny nodules, like when you got to look out for them. Like in here it looks red, pinkish. It could be lighter in other images. So just be aware of that. And these are pretty much the Kimmelstein-Wilson nodules. Very, very, very characteristic for diabetic nephropathy. And these are also pass positive. If the question mentions that the deposition, they don't mention the nodules. They don't give you a histopathological image, but they just say that there is diffuse involvement of the diffuse sclerosis of the mesangium, and there are past positive depositions. Your diagnosis should be diabetic nephropathy. There are also fibrin caps and capsular drops. So, is that clear? All right. Feel free to stop me at any point if you have any questions. Okay, next question. We have a 56-year-old female presented with proteinuria. Urine analysis shows no RBCs, no ketones, and no glucose. On ultrasound, her kidneys are small in size. What is the diagnosis? Yep, the answer is B. It's chronic glomerulonephritis. So when the glomerulonephritis or the kidney disease in general gets very late stage, the kidneys, in my words, the kidneys are cooked. So they contract and they become small, like they they're cornered pretty much. They're destroyed. So there's a very thin cortex with increased peripelvic fat. It just accumulates fat in there. It's hyalinized there. It's fibrosed. The glomeruli are fibrosed, and a lot of them are destroyed. And this overall, you could call it chronic glomerulonephritis. And the characteristic thing is that the kidneys are small in size, and you don't really see anything anymore. You don't see RBC in the in the urinalysis. You don't see ketones. You don't see glucose, but you just see loss of protein. And you can often see this in patients on chronic dialysis. Chronic dialysis is terrible, like lifestyle wise, like complications wise. It's a bad deal to have. All right. If that's clear, the next question is, we have a patient with hematuria who had amorphous pink fibrils in the glomeruli and arteries. What is the diagnosis? Yep, it is amyloidosis. Like, you have these images. If you have like a image which is light in color, I could say, yeah, if it's like pale, light in color, your diagnosis or your differential should be narrowed down to amyloidosis, or like it should be on top, because whenever it's like that, whether it's the kidneys or anywhere else in the body, if it looks like that, it could be amyloidosis, and amyloidosis is a systemic condition, so it could be anywhere. So how would you describe it? It's amorphous eosinophilic hyaline substance that can be pink or red color in Congo red stain. That is the stain being used for amyloidosis, Congo red stain. And under polarized microscopy, there's green bifringence. I still can't say that word somehow. Green bifringence in under polarized microscopy. This is very characteristic for amyloidosis, whether it be in the kidneys, it be in the lungs, anywhere in the body. These things are uniform. Okay, is that clear for everyone? I feel like I'm going a bit too fast. I don't know, but we have a lot. I put way too many questions, so we have a lot to cover. And I think at one point I stopped counting the questions. When I send the PPT, I'll put numbers before the questions. All right, towards the next step. We're done with nephrotic syndrome and nephritic syndrome and all those stuff. Right, we have a very quick answer here, but let's go through the question anyway. We have an 8-month-old infant who presented to the clinic with polyuria and polydipsia. More urine go, more water come in. That's pretty much what polyuria and polydipsia is. Baby has a large palpable flank mass. The infant dies very soon. Autopsy reveals baby's kidneys to have a smooth external appearance and enlarged numerous cysts, small cysts within the cortex and the medulla. You can see the image here. You see these tiny bubbly thingies. And you know the diagnosis. It is polycystic kidney disease, and the answer is B, PKHD1. That is the gene that is most associated with autosomal recessive polycystic kidney disease. Before we go into the explanation, let's see a question. I kind of spoiled the answer. I should have put that slide before it. But anyways, we'll go through the explanation again. The question again. We have a 44-year-old man, recurrent UTIs, brought to the ER with an ambulance for sudden onset severe headache 30 minutes ago. History of occasional mild headaches in the morning, but there is no other history of serious illness. Her father and her paternal grandmother died of chronic kidney disease. Chronic kidney disease. No fever, but the BP is high. Physical examination shows neck stiffness. When her hip is flexed, she is unable to fully extend her knee because of the pain. Lumbar puncture performed 12 hours later after a headache shows 10 ml of yellow-colored fluid with no leukocytes. Which is the following the most predisposing factor for this patient condition? The answer is sacral-berry aneurysm. A lot of the things in this question, the things I'm not sure if you guys took it already, like all this just describes like the knee extension and the lumbar puncture 12 hours later after headache shows 10 ml yellow colored fluids. It's xanthochromia, which you see in subarachnoid hemorrhage. So it's not relevant to like it's a lot of I'm just putting up this disclaimer because you're not expected to know this for your block, but what you need to know or what you need to take away from this question is that this patient has chronic kidney disease with family history. So chronic kidney disease with family history, or even if it's not diagnosed, if there is a family history of chronic kidney disease and the patient has sudden headache, and it is someone who has recurrent UTI infections, something's definitely fishy. Your differential should be narrowed down to polycystic kidney disease. So let's put these things together. So polycystic kidney disease, autosomal dominant, is what you see in adults. They're usually okay till the fourth or fifth decade. So for example, let's say our patient here, she's in her early 40s. So this is where her symptoms started to present, which is why she does not have a history of chronic kidney disease. All she has is recurrent UTI infection. So there's something fishy. And she has occasional mild headaches. And the mutation affected in polycystic kidney disease autosomal dominant adult version is PKD1 and PKD2. PKD1 is what you see in 80% of the cases, and the most characteristic things you see in autosomal dominant adult version of polycystic kidney disease are berry aneurysms, as you saw earlier, saccular berry aneurysms, and brain aneurysms, and liver cysts. So if you see this in a patient with kidney symptoms, maybe you could also have flank pain. This patient did not have flank pain because it's still kind of early. Like she had the aneurysm presentation, but she did not have a flank pain, did she? Like I don't remember reading that in the vignette. Yeah, she did have it. Yeah, she did have it because of the extension of her knee. So yeah, flank pain it's not always, but it can happen when it gets big enough and it hits the nerves that cause the pain. It could progress to chronic renal failure, but the patient, if they're lucky enough, if they take care of their health well, if they have, drink enough water, I guess, if they could remain asymptomatic. But this patient, she's 44. She's at the age, like right around the margin of the age where a patient with PKD could start presenting with it. And she had the very aneurysm, very characteristic. And if you inspect the liver of this patient, she could also have cysts in the liver. Is everything clear? Do we have any confusion or anything when it comes to polycystic kidney disease? Yeah, so the most important thing you got to remember are that in the adult version, it's autosomal dominant, it's PKD1, berry aneurysms and liver cysts are characteristic. Proteinuria, hematuria, hypertension, not really specific. Flank pain, not really specific, can progress to chronic renal failure, and patients could remain asymptomatic. We also did a question on autosomal recessive, which is the earlier questions. We saw this picture earlier, the dilation. And in the CT, you can see that there is the kidneys, you can see the kidneys are weird, right? It's bigger. And this is the one you see in neonates. It could be perinatal, it could be infantile, it could even be juvenile. Like a teenager, like even a 12-year-old kid or 13-year-old kid could also present with the autosomal recessive polycystic kidney disease, or even a younger kid. And the young kid can like rapidly succumb to renal failure, which is why the child in our case earlier, she died. The infant dies soon after. So the affected mutation is PKHD1 compared to PKD1. So when the H pops up, it's the autosomal recessive infant version of polycystic kidney disease. Majority of the cases are heterozygous. There's enlarged kidneys with smooth outer appearance. As you can see, the kidneys are very smooth and huge in the gross image right here. And you can see it's a tiny baby who's been cut open. It's sad. I think it's a preterm baby. Anyways, in almost all cases, what you see, which are characteristic for autosomal recessive polycystic kidney disease, is portal fibrosis with proliferation of portal bile ducts with liver cysts. You see liver cysts, but portal fibrosis as well. But then, you don't see autosomal dominant polycystic kidney disease in infants, I think. Don't take my word for it, but I'm pretty sure. And the gene mutation are different. So there's a lot of ways to, differentiate between the two. But usually in the exams, what they ask you is for the gene itself, or they ask you for the manifestation. For example, in autosomal recessive, you see portal fibrosis, and on autosomal dominant, you see the berry aneurysms or liver cysts, but I think liver cysts are common for both. Is polycystic kidney disease as a whole clear for everyone? All right. All right. There are a few rapid fire questions, as you saw, like with a few of the earlier questions. So this one's rapid fire too. So what is the most common congenital cause for bladder adenocarcinoma? And do we have answers? Yes. The answer is B. And something else that can also cause bladder adenocarcinoma is uterine exstrophy. And it kind of presents like this in congenitally. So both these conditions, it pretty much it predisposes the patient to bladder adenocarcinoma. There's also a third thing, which we'll be getting to later on. All right. So which of the I messed up. I clicked too far. Anyway, so which of the following is a cause of bladder cancer? A, I guess. Hemorrhagic cystitis can cause it. So hemorrhagic cystitis is, it's honestly a very important topic in medicine as a whole, because like it's associated with chemo, cyclophosphamide, pretty much. If you remember from pod, you took this in pod. Like when you were studying chemo drugs, cyclophosphamide, the main side effect which you had or which was mentioned in your portion in your syllabus was hemorrhagic cystitis. So quick throwback to that. So hemorrhagic cystitis actually increases the risk for bladder cancer, and hemorrhagic cystitis could also be caused by adenovirus infections, and it could also be caused by trauma. Trauma to the bladder can cause like infection and hemorrhagic cystitis. Like that's also possible, but the most characteristic when you hear hemorrhagic cystitis, you think of cyclophosphamide, and it predisposes to bladder cancer. Another rapid fire question, I guess. A patient was found to have interstitial cystitis or Hunner's ulcers. What do you expect to find in the microscopic evaluation in this patient? The answer is A. It is inflammation and fibrosis of all layers of the bladder. So Hunner ulcer is common in women. It is associated with SLE. As the leak comes back, the etiology is not very unknown, and there is chronic suprapubic pain, also noticed in these patients. Interstitial cystitis, you think of Hunner's ulcer, and it's inflammation and fibrosis of all layers of the bladder, every layer of the bladder. Von Brunn cysts, I think that was one of the answers being told. Yeah, B. Von Brunn cysts, we'll be talking about them right here. So which of the following describes the origin of the cyst seen in this image? Von Brunn nest. It's A. So that's what is the source of this these things right here. And this particular presentation is cystitis cystica glandularis, which is a type of manifestation you can see in chronic cystitis. Let's briefly look into more images on how chronic cystitis can present. Von Brunn nests are what you see right here, like before, and from these nests are where these lesions form or come out of. And it could present as cystitis cystica, which presents like this, or it could be cystitis cystica glandularis, where you see more glandular cuboidal cells being formed in here. So these are just slides from your presentation. I'm frankly not very sure how important this is for your exam point of view. They could bring you something like this in your OSCE, they'll show you the picture and ask you to diagnose it, or tell you, okay, there's this, and like the question I just mentioned, they show you this thing and they tell you what is the source of this presentation, and it is because of the Von Brunn nest. That's where it comes from. All right, is this stuff clear? It's pure memorization. That's all there is to it. 90% of almost everything about renal is pure memorization, except the clinical stuff, I guess, and the stuff I talked about in the earlier, the acute tubular necrosis and acute kidney injury, things like that, and the metabolic disorders. All right, let's move on. What do we have here? We have a 43-year-old male presents with chronic cystitis. Biopsy of the bladder shows sheets of cells with round laminated concretions appearing like halos. The patient also complains of a previous UTI prior to developing this condition. Which of the following organisms is the most likely cause for this presentation? The answer for this is Proteus mirabilis. What we're seeing here is malakoplakia. And the little round laminated concretions appearing like halo, these sheets are the Michaelis, what do you call it? Michaelis Gutmann bodies. Funky business. Anyways, yeah, that's what they are. The Michaelis Gutmann bodies are what looks like these halo thingies. And patients with Proteus or E. coli, previous infection, if they present like this particular type of chronic cystitis is malakoplakia. Yep. All right. We're progressing pretty fast. So is everything clear so far? Dying, but okay. It's all right. You'll figure it. You just need one more review and you'll figure it out. Now, there's a lot of these random stuff like malakoplakia and all that. Honestly, like a lot of this is not that important for boards. If you're worried about that, I'll tell you what's important for your step one exam at least. Nephrotic syndrome. That's pretty much the bulk of it. And acute tubular necrosis, acute kidney injury. As long as you know nephrotic syndrome and all the subtypes that comes under it, like IgA nephropathy, mainly IgA nephropathy and post-strep glomerulonephritis. These two are the biggest things there is from all of renal pathology that for board's perspective, IgA nephropathy and post-strep, like these two are the things that you need the most. But for your uni exams, uh, yeah, things can get a bit tricky because they're very in depth into the details, like all these different stages for SLE, for example, which can be annoying. But you can just associate it with how bad the patient is. If the patient is doing really bad, like they are, really like the presentation, like the urine creatine is super high, or like it's terrible. At that point, you can tell, okay, this is diffuse sclerosis. It is class 4, things like that. But the questions that comes in the exam are usually very simple, so it shouldn't give you a hard time. One more review is all you need. You don't need to freak out. And the stuff here onwards is very straightforward. If you don't know it, you'll know it right after this. So we have a previously off. And I keep pressing next. Hate when I do that. Spoiler alert. Anyways, we have a 19-year-old man, very young guy. He has a right-sided dull throbbing scrotal pain for 12 hours. He also had burning sensation of urination, increased urine frequency. He had urethral discharge. He's sexually active with one female partner, and he does not use condoms. Hairless guy, and the vital signs within this are within normal limits. He has a tender right testicle, and lifting it provides relief. The penis appears normal, no discharge, nothing. Lab studies show normal CBC. Urinalysis shows 3 WBCs. Gram stain of the urethral swab shows polymorphonuclear leukocytes, but there are no organisms. Like you only need this one line to find the diagnosis, or like what bacteria we're dealing with here. Scrotal ultrasound shows, or testicular ultrasound shows increased blood flow in the right testicle compared to the left. Which of the following? You guys saw the answer already. It's chlamydia. Yeah, it's chlamydia because gram stain showed nothing except leukocytes. And now you have two differentials. What are the two differentials you would have from this? Like two conditions. It could be. It is epididymitis and orchitis. So first off, we need to identify the organism involved. So if it's a male patient under 35, it could be due to chlamydia or gonococcus. And the gram stain gives you the answer here. If the gram stain shows nothing except polymorphonuclear leukocytes, it's chlamydia, which is why F is scratched out of the answer, which could, because without this line, F might as well be the answer. But if it's a male over 35 years old, the cause for acute epididymitis or orchitis is E. coli or Pseudomonas. Clinically, how would such a patient present? Sudden pain developing in the scrotum with rapid unilateral scrotal enlargement and tenderness extending to the spermatic road. So how to differentiate between epididymitis and orchitis is by the Prehn sign, P-R-E-H-A-N sign, where lifting the scrotum or the enlarged area gives relief if it is epididymitis. This Prehn sign is not positive in orchitis. That's the difference. Is that understood? Amazing. So we have a 14-year-old boy now. He's brought to the physician by his mother for a history of fever and malaise. His left cheek has grown in size over the past 3 days. He has a known HIV infection. This patient is immunocompromised, transmitted during the pregnancy. He has a fever. He has parotid gland enlargement bilaterally and swollen non-tender cervical lymph nodes. His skin appears normal. The patient here is at the greatest risk for what? Yes, the answer is C. It is orchitis associated with mumps. So this immunocompromised patient, he has HIV. So he also contracted mumps along with it. So it happens in post-pubertal children, and there's interstitial orchitis that happens like a week after swelling up the parotids. Presents as a mass and is usually unilateral. Very straightforward. All right, next question. We have a 14-year-old boy. He's brought to the ER because of severe lower abdominal pain in the right groin area, nausea, vomiting for 2 hours. He has been playing soccer with his friends, football with his friends, American question banks. Anyways, so football with his friends and started experiencing pain while walking home. He has never experienced similar symptoms before, but he has no other history of serious illness. He does not take any medication. He appears ill. He looks sick. He is not okay. He's in a lot of pain. So his temperature is 36 degrees. His pulse is 90. His respirations are 18. Bit slightly depressed, but like it's still normal. BP is a bit elevated, 140. Right scrotum appears mildly swollen. There is severe tenderness and palpation. And stroking the inner side of the right thigh fails to elicit an elevation of the scrotum. This is a chromatic reflex. Which of the following is a diagnosis? It's testicular torsion. Testicular torsion is a painful condition, very painful. They say it's rare, but I know at least 3 guys who've had testicular torsion. It's crazy. Anyways, so let's talk a little bit more about it. It is a medical emergency. Yeah, it's insane. Maybe I just ended up meeting a cohort of people who had testicular torsion. So yeah, what happens is that the spermatic cord gets twisted, and this leads to hemorrhagic infarction. That sounds nasty enough. So, and what leads to it is greater mobility from incomplete descent or a lack of scrotal ligament, which predisposes to this condition. So, there is a certain abnormality called the Bell-Clapper anomaly, where a certain ligament, a scrotal ligament, which is supposed to hold the testicle in place, is not there. And this ligament is tunica albuginea. When tunica albuginea is absent or the patient has Bell-Clapper anomaly, his risk for having torsion increases a lot. So the treatment is surgically untwisting it. It's a medical emergency where you send the patient immediately to the OR. It's a surgical untwisting, and you suture the cord in place to prevent future torsion or infarction. And it needs to be done quick. It should be done within 6 hours. Are we good so far? Great. So here we have a 32-year-old man who comes to the physician because of a 3-week history of painless testicular mass. He first notices he first noticed that while showering, he does not smoke cigarettes. His physical examination of the right testicle shows a firm, fixed, non-tender 2 centimeter nodule. When light is held to the scrotum, there is no transillumination. Ultrasound shows a well-defined, homogeneous hypoechoic 2.3 centimeter lesion. You didn't see that. Hypoechoic 2.3 centimeter right testicle lesion. Lab study shows increased serum concentration beta-HCG and placental alkaline phosphate. Your emphasis is more on beta-HCG, to be honest, and placental alkaline phosphate as well. But the alpha fetoprotein is normal. So these two lines are pretty much what helps you narrow down your diagnosis. And serum alpha fetoprotein is normal in here, but the patient has increased beta-HCG and placental alkaline phosphatase. I don't think placental alkaline phosphatase was mentioned in your lecture, but maybe it's in one of your clinical lectures. I'm not sure. But yeah, they could just mention this in your exam. Just remember that is for seminoma. He mentioned it? I don't remember reading it in the pathology lectures, but if he did, great. All right, so there's a right radical inguinal orchiectomy is performed. They took it out pretty much, and this is what it shows. And this patient has seminoma. Palp, yes, palp. That's what it is. It's placental alkaline phosphatase. And the image you see right here is very characteristic. You call this fried egg appearance for seminoma. Just remember this image well. And this presentation, increased beta-HCG, increased palp seminoma. There you have it. Yeah, there's a lot of fried eggs. All right, so for seminoma, it looks like this. It's like a pale tumor. It's not yellowish. Yellowish would be something else, which we'll talk about in a second. It's kind of like a pale tumor. It looks like a heart. Not going to comment on that. So anyways, these are two images. Both are from your lecture. And it happens in 30 to 50-year-old patients. And patients who are much younger, it's patients who are much younger, it's usually embryonal carcinoma. Germ cell tumor, it is a germ cell tumor, and testicular tumors are classified into germ cell and non-germ cell tumors. Non-germ cell tumors, I guess you'll be taking it in NDREP. You take Sertoli and Leydig cell. I'm saying too many words that are unnecessary, so pretend I never said that because you don't have it in your exam. So your focus will be on germ cell tumors in your renal final, and it is highly, highly associated with cryptorchidism. What is cryptorchidism? I'll get to that in a second. So this is highly radiosensitive, and it's beta-HCG positive, and it's spelled wrong, I guess. PALP positive. It's supposed to be PALP, placental alkaline phosphatase. And these are the characteristic images that you should remember: fried egg appearance, whatnot. And the picture on the right, I hope you can see my cursor here. The picture on the right you see is that on the left side of this image is in situ tumor. It's an in situ germ cell tumor. On the right side, it's fully manifested and to a seminoma. Yes, cryptorchidism is undescended testes. And that's what our next slide is on. So cryptorchidism, it's undescended testes. It increases the risk for testicular cancer. Yeah, so the left side, 1 second. So wait. Yeah, see how the basement membrane, or like there's a septum right there separating between the two layers. That means it hasn't invaded the basement membrane yet. So it's in situ, IGCN. Is that clear? So what right side is seminoma? Yeah, if you zoom in more, you'll see the halo and the dot in the center, the fried egg appearance. You'll see it when you zoom in. So whatever tumor it might be, like it could be in renal, it could be in any sort of system. If you're suspecting an in situ tumor, look for the basement membrane. If you see that the basement membrane is clear, if you do see some order of some degree of order, like there's a layer and there's like funky business happening in one side and there's a layer that separates it from the other side, that means the tumor or whatever it is in situ. It is still within bounds. It's not gone too far yet. Back to cryptorchidism. It increases the chance for cancer 3 to 5 times more. So, and It is unilateral in 75% of the cases, and early on, even as a kid, like while it is undescended, they could have a foci of intratubular germ cell neoplasia, which is IGCN. And it could cause sterility. It could also cause a concomitant hernia. And the patient, if there's any abdominal trauma that the patient has while the testes are still undescended, it could make the patient unstable. So it's trauma, direct trauma to it is also very risky. So what's recommended for a patient with cryptorchidism is orchipexy, where you pretty much pull it out and place it right, orchipexy, before the age of 10 to reduce the risk for cancer. And it's pretty much damage control. So to quickly go over the other testicular cancers, I just mentioned the things that you should look for in the question rather than go into a billion different details. So for embryonic carcinoma, the age group that you got to see is 20 to 30 years old. What did we see in seminoma? 30 to 50 years old. So if it's younger than 30, but still like a young adult, 20 to 30 years old, pretty much our age group, it's embryonic. It could be embryonic carcinoma. You could see both elevated beta HCG and AFP, or you could see both negative. Like in your lecture, in the slides, it's mentioned that beta HCG and AFP are elevated in 90% of the cases. This is what mentioned in the slides. But the doctor placed a table at the end which says that beta HCG and AFP are negative in embryonic carcinoma. Other sources said it could be both. That's what it means. It could be both. It could be elevated and it could be not elevated. That's what that means. And it has a very primitive appearance. As you can see, it's all over the place. It looks like TV noise. Like it looks like noise. So that is embryonic carcinoma. It's all over the place. Yolk sac tumors, on the other hand, are endodermal sinus tumors. If I'm going to rank these tumors based on how high yield they are, number one would be seminoma. Number two would be yolk sac or endodermal sinus tumors. And this is the most common testicular tumor in infants and children. What's characteristic about it? It's elevated AFP. Elevated AFP is yolk sac tumor. Elevated beta HCG is seminoma. And gross, this one looks yellow. Yolk sac tumors look yellow. It shouldn't be hard to remember because yolk sac, come on. It's yolk sac, yellow, yellowish appearance. And the most characteristic histopathological image or presentation in this is the Schiller-Duval bodies, which is the image you see on the side. It's pretty much like a flower. Yeah, excoming shell Schiller. Excoming shell. Yeah, that's a good way to remember it. Yeah, that works. Take notes, I guess. Eggs come in shells. Schiller-Duval bodies, yolk sac tumors. So how would it look like? It looks like a flower. I think how it is usually described is something else, but this is how I remember it for some reason. It's like this, like a little circle with cells all over the place, like in the periphery. And in the center, there's a blood vessel. It looks red in the center. So yeah, it looks like a cinnabon. It could look like a lot of things, but once you get the image, you know it. And in the center, there's a blood vessel. So that's the Schiller-Duval body. Next one we have is choriocarcinoma. This one's a bad one. It's nasty. It's aggressive. It's lethal. They even the doctor put like a crazy image in here. It looks red and high contrast and messy. Even the histopathological image, it's all over the place. Like, what am I supposed to look at here? Like, it's crazy. And what's characteristic about choriocarcinoma? It's syncytiotrophoblaст formation and also cytotrophoblaст formation. Do you remember these words? I don't know, but syncytiotrophoblasts and cytotrophoblasts are pretty much embryonic tissue, and they secrete beta HCG a lot. They secrete beta HCG, so this has very high beta HCG levels. And the tissue itself, it could be mixed. It could have like what you expect to see syncytio and cytotrophoblasts both, and it could be by mixed. I mean the presentation could be all over the place. That's what it means, because it's more of an embryonal tumor and it's aggressive and lethal. And what makes it even weirder is that the tumor presents, there's no enlargement. It presents as a small nodule. Like in the testes, it's a small nodule. There's no enlargement. It's weird. Teratoma, on the other hand, there's multiple germ layer involvement. You'll see body parts in it. Like it's weird. A teratoma could be you'll also take teratoma in NDREP along with choriocarcinoma for the female side of things. So teratoma, there's multiple germ layers involved. like all kinds of germ layers that are supposed to make a wide array of things like tooth, hair, etc., whatnot. It's seen in infants and children, and it is usually benign in infants and children, but non-adults, it could be malignant. So malignant is immature teratoma, and the benign one, which you see in kids, is mature teratoma. There's nothing elevated in this. There's no beta HCG elevated. There's no alpha fetoprotein. There's no PLAP elevated. Nothing's really elevated. You just see a mass, and histopathologically, it looks like this. It's non-specific. Multiple germ layers are involved. There you have teratoma. So the only two tumors where nothing in particular is elevated is teratoma and embryonic carcinoma. Although in embryonic carcinoma, these could be elevated. But one way to differentiate between them is that teratoma happens in infants and children. Embryonic carcinoma happens in young adults. Are the testicular tumors clear for everyone? Dope. Yes. Can we have a quick prayer break? Yes, that's a good idea. I was going to say it too. So, do we have the host in here? Like the organizer? So that they can pause the recording? Let me see. Amazing. So let's continue. All right. So our next question, we're almost done here. Our next question is a 59-year-old man comes to the physician because of urinary frequency and perineal pain for the past 3 days. During this time, he has only had pain with defecation. He is sexually active with his wife only. He had a temperature of 39. He has fever. His penis and scrotum appears normal. DRE shows a scrotal, swollen, exquisitely tender prostate. His leukocyte count is 13,000. It's very typical for an infection. So a urine culture obtained prior to initiating treatment is most likely to show which of the following. Yes, the answer is E, gram-negative, lactose fermenting, rod and ping colonies. It's E. coli, and what the patient has is acute prostatitis. Acute prostatitis is a prostate infection. It could be due to urethral catheterization. And the presentation that you expect to see in a patient like this with acute prostatitis would be lower back pain. Anything to do with prostate, anything to do with prostate, you can expect to have lower back pain. Dysuria, painful urination, which is perineal suprapubic discomfort, and DRE, the patient will be in pain in DRE. The patient will have recurrent UTIs. I don't know why this says recurrent UTIs in men. Oh, okay, never mind. It's about the remaining rest of the sentence because I don't think it makes much of a difference. Recurrent UTIs in men in prostatitis. Anyways, moving on. Recurrent UTIs in men can be due to underlying prostatitis. Underlying prostatitis can cause the patient to have recurrent UTIs. And the most common organisms, like we saw earlier, E. coli, gonococcus, chlamydia, and staphylococcus are the most common organisms. Biopsy is not done in prostatitis, except if it's a patient who underwent BCG installation for urothelial carcinoma. Urothelial carcinoma can be treated with BCG installation. Extra point. And this situation will be granulomatous prostatitis. And in this case, we do biopsy just to see, we do biopsy. All right, the next question, you see that the question is looking different because this question is from Robbins. I would highly recommend going through both the files for Robbins, for kidney and male urinary tract. Go through both files if you have time. Once you're done with past exams and once you're done with your lectures, absolutely go through Robbins because Drs. Abrar and Oban, they both love to bring questions from Robbins or use Robbins questions as their template. So let's read this question. 65-year-old man, multiple recurrent UTIs for the past year. E. coli, streptococcal organisms have been cultured from his urine during these episodes. Bacterial counts for more than 10 raised to 5. He has difficulty urination, including starting and stopping the urinary stream. Over the past week, he once again has developed burning pain with urination, dysuria. Urinalysis now shows pH of 6.5 with specific gravity of 1.020. No blood or protein. Tests for leukocyte esterase and nitrates are positive. Microscopic examination of the urine shows numerous WBCs and few WBC counts. Which of the following is the most likely condition predisposing him to recurrent infections? What is the answer? Age of the patient. He's 65 years old. When a 65-year-old patient comes up, 65-year-old patient comes up with multiple UTIs, difficulty urination, things like that, you should always think of BPH or NPH, benign prostatic hyperplasia or nodular prostatic hyperplasia. Someone did say F, vesicular-urethral reflex. This is right. This could be true if we're dealing with a small child. If it's a child who has recurrent UTIs, vesicular-urethral reflex is a great answer. But for a 65-year-old male, the biggest thing will be NPH or BPH. So if you see like an old patient with similar symptoms, absolutely have this in your differential. So let's talk more about it. It's very prevalent. It could be subclinical. It could not present. In a lot of people, a lot of men over the age of 40 have NPH. And it's proliferation of both stromal and epithelial cells. And what causes it is it's androgens. It's very androgen dependent. And because of the continuous exposure to androgens, the prostate enlarges. There's more proliferation of stromal and epithelial cells. It's a very pathognomic sign of aging as a whole. It presents with difficulty in initiating the urinary stream. Wait, back. Okay. Difficulty in initiating the urinary stream, hesitancy, interruption from the urinary stream, dribbling after urination, and even increased frequency of urination could also be seen. And recurrent UTIs is also something that could happen with NPH or BPH. Let's get more into the pathological aspects of it. Where the nodules are formed or the enlargement happens or the hyperplasia happens is in the transitional or the central zone of the prostate. This could be a question in your exam. They could ask you where exactly it is. It's a first-year question, but they could ask you this again here. Transitional or the central zone of the prostate is where NPH happens. And treatment is tamsulosin, alpha antagonist, finasteride, and TERPs. TERP is basically you go in, and if it's like really big, and you break it down into a powder, and then you take it out. That's TERP. So yeah, there's that. Finasteride is I believe it's an androgen receptor antagonist. It's also used for hair loss. So yeah, in the rectal examination or the DRE, it's firm and rubbery. Any questions on BPH? Great. All right, so that's BPH. Next question, once again from Robbins. We have a 45-year-old male this time who comes to the physician for a routine health maintenance examination. On physical examination, there are no remarkable findings. Lab findings show serum creatine 1.1, urea 17, glucose 76, alkaline phosphate 18.9, PSA is 16. PSA is 16, pretty high. prostate biopsies are performed and the high-power microscopic appearance of the biopsy specimen is shown in the figure. You can see the figure on the right. Which of the following is the most likely risk factor for his disease? So I think you can tell that this is prostate cancer. So yeah, the answer is A. It's epigenetic hypermethylation of GSTP1 gene. Let's talk more about it. So prostate adenocarcinoma is the most common tumor in males, and it is located in the posterior or the peripheral zone. So remember this: central zone, benign prostatic hyperplasia; peripheral zone, or the posterior lobe, is prostate adenocarcinoma. It is uncommon before the age of 50, and as you get older, when you get like in your 80s and whatnot, the rate increases a lot for prostate adenocarcinoma. But the risk factors are because of androgens, because it could be hereditary, it could be due to environmental factors, it could be like epigenetic factors. Epigenetic factors is what the question asked earlier. Hypermethylation of GSTP1 is an epigenetic factor. So it could be resistant to anti-androgen therapy due to overexpression of androgen receptors. This is a subtype of prostatic adenocarcinoma where they're resistant to anti-androgen therapy, like finasteride. The hereditary association has to do with the MYC oncogene in the position AQ24. Remember MYC oncogene? Environmental, more Western diet, like an American diet, could also increase prostate adenocarcinoma risk factors. Asians, like our people, or Arabs, our people, we have a good variety of diet, but so we're cool. But the more Western our diet becomes, the more health issues we're having. So it could also be due to an acquired mutation. It's TEMPRESS2 ERS. It looks funky. If it comes in if they bring you a prostate adenocarcinoma question in SAQs, good luck spelling this. So just memorize it, I guess. But I think whoever's correcting it, if you like miss a couple S's or R's, I think they'll get the idea and still give you the score. But anyways, remember it. Epigenetic change is hypermethylation of GSTP. If you don't know what epigenetic basically means changes to the things that affect the genes. Hypermethylation, acetylation, things like that is what modifies the expression of genes. So these changes are what you define as epigenetics. So what is the epigenetics we're dealing with here? There's hypermethylation of the GSTP1 gene. And this particular change is seen in about 90 to 95% of the primary prostate adenocarcinoma. There are both hematological and lymph metastasis in prostate adenocarcinoma. Osteoblastic bone metastasis, the most common metastasis when it comes to prostate cancer, is a hematological metastasis. This could be a question in your exam. Like they could ask you, okay, how does prostate metastasis happen? What route does it take? You could tell the answer is hematological. And it usually presents with the spine. You can see the picture down here, and you also have high ALP these mets. So anything which affects the bone, the osteoblast of the bone, could have high ALP. Elevated PSP is PSA is very sensitive, but not specific. So if a patient has elevated PSA, it really raises the questions for prostate adenocarcinoma. Although the in situ variant does not elevate PSA. So for once the therapy started, serial PSA measurements is done to see if the patient is improving. So if the levels are decreasing, that means okay, the therapy is working. The patient's prostate cancer is getting smaller, I guess. So if the levels are over 4, in general, there is something wrong. If the levels are over 10, it has a high predictive value for cancer. So what did our patient have? He had, I think, 11, wasn't it? How did I go? Oh, never mind. He had 16, so it's pretty high. So it's a pretty good predictive factor for cancer, even without the biopsy. So here we have the next question. I kind of showed the answer already, but anyways, at this point, I think it's pretty predictable what the questions are going to be. So, so we have a 65-year-old man recently retired after many years in a job that involves exposure to aniline dyes, including beta-naphthylamine. 1 month ago, he had an episode of hematuria that was not accompanied by abdominal pain. Physical examination, there was no abdominal findings. Urinalysis shows 4+ hematuria. He has really good, like bad hematuria, and no ketones, glucose, or protein. Microscopic examination shows RBCs that are too numerous to count, 5 to 10 WBCs per high power field, no crystals or casts. The result of the urine culture is negative. Cystoscopy is performed, and the biopsy of the lesion reveals microscopic appearance in the figure. You can see the figure right here. Which of the following neoplasm is the most likely to have? Do we have an answer? The answer is urothelial carcinoma. It's not, yeah, it's E. Although renal cell carcinoma does have hematuria, like it could even be massive hematuria. This one with the risk factor, which is aniline dyes and naphthylamine, it narrows down your diagnosis again because that risk factor is particularly for urothelial carcinoma. And of course, they mentioned that they did a cystoscopy, and the biopsy was taken from a cystoscopy. So once again, you should be thinking of the bladder. So cystoscopy, bladder, so urothelial carcinoma. Let's talk a little bit more about it. So urothelial carcinoma is 90% of the bladder tumors. Risk factors include cigarettes, arylamines, or weird funky chemicals, pretty much. Schistosoma could also cause bladder cancer. That's it's a bit of a stick to it. Schistosoma usually causes squamous cell carcinoma, not urothelial carcinoma. So if the in your exam you see a question and they describe a patient with cancer symptoms, which including hematuria, back pain, whatnot, and cystoscopy showed cancer, and the patient has a history of schistosoma exposure, and they ask you what type of cancer is this? It's not urothelial carcinoma. If the question comes like that, it's the best answer would be squamous cell carcinoma if the patient has schistosoma exposure. It is included in this list of schistosoma. Urothelial carcinoma schistosoma is included in this list of urothelial carcinoma risk factors because it could be caused by it. But schistosoma exposure, the first thing you should think of is squamous cell carcinoma. Moving on, long-term use of analgesics, hemorrhagic cystitis, and radiation could also cause it. Bladder adenocarcinoma could be caused due to, as we talked about earlier, exstrophy, patent urachus, and urachal cysts. If a patient has any of these congenital anomalies and if they're at risk for any type of cancer, it is bladder adenocarcinoma. Not urothelial carcinoma, not squamous cell carcinoma. Bladder adenocarcinoma is these three. We have the images right here. Is it clear so far? Bladder cancers. Great. All right. We have a 69-year-old man who comes to the physician because of 1 week history of blood in the urine and fatigue. He also had a 5 kg. He also had a 5 kg weight loss during the month. Physical examination shows pallor and cachexia. So far, you saw 3 things that just screams cancer, which is weight loss, pallor, and cachexia. And there's non-tender right flank mass palpated. There's CT scan of the abdomen, chest, abdomen, and pelvis shows a right 5 centimeter right upper pole renal mass, several pulmonary lesions, and a biopsy of the affected area of the lung is obtained. A photomicrograph of the biopsy specimen is shown. Oh, where's the image? The image is missing. Anyways, you guys got the diagnosis anyway. It is VHL. And the molecular evaluation of the specimen is most likely to show which of the following genetic changes. The answer is yes, VHL gene deletion. And what we're dealing with is renal cell carcinoma. I don't know what happened in the image, but you'll see it soon enough anyway in the next slide. So here we have renal cell carcinoma. The image on the right is image on the top right is what you're supposed to see in the earlier slide. It's very, very typical image for renal cell carcinoma. It's this white image with a bunch of dots in it. Really, that's pretty much characteristic. So renal cell carcinoma, it's in older individuals, more in males, and most of it is primary. The risk factors include smoking, like with literally every other cancer, dialysis-associated cystic disease, uh, tuberous sclerosis, obesity, industrial chemical exposure like cadmium, and even autosomal dominant PKD could lead to renal cell carcinoma. So the familial types are von Hippel-Lindau syndrome, or which is where the gene's name comes from, VHL gene, which is a triad of CNS tumors, hemangioblastomas of cerebellum, and renal carcinoma. So if you get a question where the patient's having neurological symptoms, and he's also having symptoms that makes you think cancer and also renal cancer, such as, let's say, flank pain and hematuria, an abdominal mass, and a palpable abdominal mass, you should be thinking of von Hippel-Lindau syndrome, you should be thinking of von Hippel-Lindau syndrome. The patient would also have hereditary version of it, which is hereditary clear cell carcinoma. Once again, it's VHL gene mutation with a renal tumor, but there is no CNS tumors, which you would see in von Hippel-Lindau. Hereditary papillary carcinoma could also be seen, but the mutations are in the MET oncogene. The picture below is the papillary carcinoma, papillary renal carcinoma, where you see Samoma bodies. Samoma bodies are the dark things, the dark little dots right above the text box, which I've put. The most common presentation, once again, is hematuria. There's a triad that you can expect. Oh, we're done. There's a triad that we can expect, which is hematuria, palpable abdominal mass, and dull flank pain. Lung metastasis can happen. So if a patient starts coughing up blood and you also see renal cell carcinoma, it's lung metastasis. And cannonball appearance is very typical. Like if you see it, the CT will show like bunch of like dots on the. It's like it's a bunch of hyperechoic dots in the CT image. That's cannonball presentation. Renal cell carcinoma could also predispose a patient to having varicoceles because of increased risk of thromboemboli, which goes into the renal vein and causes the varicoceles. So that's renal cell carcinoma. Do you have any questions?
No, thank you so much.
All right, great.
Really, it was so comprehensive.
Thank you. I'm glad to hear that. I hope this was helpful, and you guys are stressed out for the exam. It'll be easy, inshallah. I hope I was able to help, and thank you for staying and being attentive throughout the whole thing. And have a nice day. Assalamu alaikum.